Okay, so guys, today I'll be summarising a study that we did here in WA in Western Australia over a 2-year period. This is the first ophthalmic randomised clinical trial to look at the treatment of diabetic macular edema, specifically in the Australian Aboriginal patient subgroup. Okay, so obviously lots of research has been done on diabetic macular edema in various other patient groups all around the world for quite some time now, but there had never been a study looking specifically at the Aboriginal population. And this is a group of patients that many of us see and treat quite a lot here in Western Australia. So we thought that it would be useful and appropriate to try and conduct a study looking just at these patients. So this is what I'll be summarising for you today. It was an investigator-initiated study which was sponsored by Allergan, but there were no conflicts of interest and the sponsor had no role in the design of the study. The background is that the prevalence of diabetic retinopathy and diabetic macular edema are higher in Aboriginal people in Australia compared to non-Aboriginal people. So if you look at the top row there, the top bar, it will show you that the prevalence of diabetes itself, type 1 and type 2, is almost triple that in Aboriginal people compared to non-Aboriginal people. And there are many reasons for this. Vision loss from diabetic retinopathy, again, it's more than triple in Aboriginal compared to non-Aboriginal people. And not surprisingly, most of that vision loss is from diabetic macular edema. The image that we've got down the bottom there is trying to show that there's a balance between the number of injections that are needed to adequately treat someone with DME versus the duration of action of the drug. So what I'm saying there is if you've got a drug that lasts a month, you're going to need more injections. Longer duration of action, you're going to need fewer injections, and I'll explain why that's important to this group. Basically, in the outback setting where a lot of Aboriginal people live, not all of them, but a lot do, the drug that traditionally we've had available to us is Avastin or bevacizumab. This is because it's easy to acquire and it's easy to transport to a district hospital. We don't need any special application for it. And you can have a consignment stock kept almost in any clinic in the state of this drug. And traditionally, this is what we've used. However, the longer acting drugs have been available, and several years ago now, the intravitreal dexamethasone implant came out, where the duration of action was shown to be 3 months up to 6 months. And there are some side effects with dexamethasone, but we thought that this would be a useful drug to compare to bevacizumab in this particular patient subgroup because they would not need as many injections. And the lack of attendance and the difficulty in treating people, say 8 to 10 times a year, which is really what they need with anti-VEGF, at least in the first year, we thought perhaps there's an opportunity here to get around that by using a longer acting intravitreal steroid implant. So what were our methods? This was a prospective phase 4 multi-center randomized active controlled non-inferiority trial. So we were hoping to demonstrate, well, the question we were really asking was, is dexamethasone at least not inferior to Avastin? Perhaps it's superior, but we're asking the question of whether it's not inferior. So in 2 years, we were able to enroll 63 eyes from 51 participants, and we got the local ethics approval as well, of course. And the patients were recruited from all over the state. Some were recruited from Perth, the state capital itself. But as you can see from the image there, patients came from all over the state as far as 3,000 kilometres away from the capital in Perth. What was the intervention? Well, as I've said, it's the dexamethasone implant versus bevacizumab, and it was a 1-to-1 randomization. The study design was that we'll attempt to see every patient in this trial every month, whether they get an injection or not. Now, in the case of Avastin, at every visit, we're going to inject them. That's the intention. So we're aiming for 12 injections a year, knowing that we're very likely not going to achieve that, but that was our intention. And with dexamethasone, we're aiming for 4 injections a year, so 1 injection every 3 months, but with monthly review so that intraocular pressure and cataract formation could be assessed. And then laser and other surgery could be performed as needed. The primary outcome was that we were looking at the upper bound of the 90% confidence interval of the difference in effect between the 2 interventions. Now, I'll explain this more a little bit as we go along, but essentially that's the test for non-inferiority. And we're looking at the difference in vision, the best corrected vision, from baseline to 12 months between these 2 treatment arms, and the non-inferiority margin was 0.1 logMAR between the 2 groups. So what were our results? Well, here's the consort diagram. So we started off with 63 eyes which were eligible. 4 were excluded. They didn't actually meet the criteria. The rest were randomized, and then some withdrew, and others, the patients self-withdrew themselves. In others, we had adverse events. And so we ended up with 26 in the Avastin arm and 22 in the dexamethasone arm. And so here's the first result. The top one, the dashed vertical line that you see there is the threshold for non-inferiority. And so, and to the left of the bars is results that favor dexamethasone, and to the right of the image is results that favor bevacizumab. So what the top one shows was that the visual results favored dexamethasone for the whole group overall in a way that did meet non-inferiority. This is for the whole group. So for the whole group, the dexamethasone implant was found to be non-inferior to bevacizumab. The second image, the one that's lower down, shows the results after you control for the effect of cataract surgery performed during the trial. So when we remove the effect of cataract surgery performed during the trial, then you can see that the result just crosses over with the non-inferiority threshold. This means that it approached non-inferiority, but it was not non-inferior. Dexamethasone, after you control for the effect of cataract surgery, was not found to be non-inferior. Now, I'll talk about this more in a moment, because in Australia, you actually have to perform cataract surgery in order to, the patient has to be pseudophakic or has to be scheduled for cataract surgery at the time that they're injected with dexamethasone. So in a sense, the top result is more relevant to Australia because you have to have done cataract surgery or be doing it soon. But it does raise the question of some settings where it's difficult for a patient to have access to cataract surgery. So let's say you're in the middle of nowhere and you inject someone with dexamethasone, you almost have to have a guarantee, if they're phakic, that you can get that person to theatre somewhere, somehow. And this is one of the challenges of performing outback work. But again, just to reiterate the results of this particular, these are the top line results. Overall, as a group, dexamethasone was found to be non-inferior. But after you control for cataract surgery, it just misses out on that non-inferiority threshold. Okay, so here's the change in VA. The orange or red line represents bevacizumab, and the dashed turquoise line is dexamethasone. So you can see that at the 12-month mark, these are logMAR results. The Avastin group, the bevacizumab group, actually had worse vision, whereas the dexamethasone group, on average, had better vision. So overall, at the end of the 12 months, better vision in favor of dexamethasone for the whole group. Here's central macular thickness. So not surprisingly, intravitreal steroids are known to be particularly good for central macular thickness. And so you can see that again, the dexamethasone group had a greater mean reduction in central macular thickness after 12 months. Now I'll see if I can get this to work. So here's the number of attendances. So overall attendances were higher. If you look on the left, this is patients who were seen in Perth, metropolitan setting, versus patients seen on the far right-hand side in a regional setting. And overall attendances were higher in Perth, not surprising, easier for city patients to get to a city clinic. And also we ophthalmologists may only visit a country site 6 times in a year, whereas we're more likely to be present in the city site every single time. The next one will show you, oh, it's just disappeared. Apologies. Okay, so here's the number of injections. So remember that we were aiming to get 4 injections of dexamethasone. So in the city, we pretty much achieved that. In the country, we got 2.5, let's say, to 3 injections. But as a proportion of the number that we were intending to administer, in the country especially, we got much closer to injecting how many we intended as far as dexamethasone, let's say 3 out of 4, compared to bevacizumab, where we got 5 out of 12. So again, this just shows that this steroid, you're going to get closer to your intended number of injections per year. In the city, you're pretty much going to get 4. And in a country town, you're going to get 3, which is not terrible. You compare that to 5 out of 12 Avastin, 5 Avastin injections for the average person with DMO. It just isn't going to be enough. In the city, however, 10 Avastin injections almost, that's a pretty good result. And this just reflects the proportion of intended treatments. So again, as you can see, the proportion of intended treatments good with dexamethasone, but worse with Avastin in country areas. Okay, here's the change in vision compared between city patients and country patients. So on the left-hand side, you can see that Avastin was actually better. So in the city where Avastin patients were able to receive 10 injections, they end up with a greater improvement in vision. Again, remember this is logMAR vision. In the country, it was the exact opposite. So patients who received dexamethasone got a far better visual result than those that were receiving Avastin. And this was the result that we suspected. And it reflects what I just showed you, which is that in country patients especially, dexamethasone patients are getting 3 out of their 4 injections. Avastin patients are only getting 5 out of their 12, 5 or 6. Hence, country patients in particular are benefiting from intravitreal steroids. So the take-home points here was that the dex implant was not non-inferior to Avastin after you adjust for cataract surgery. However, it was non-inferior when you combine with cataract surgery. And the point I was making earlier was that you have to combine it with cataract surgery in Australia. So for this reason, we think the second result is a more real-world result for Australia, as long as you can ensure access to cataract surgery for patients in any location. So if you're thinking about intravitreal dexamethasone, at the same time, you have to be thinking about cataract surgery if they're not already pseudophakic. The next point is that there were fewer attendances required, fewer injections required, and superior clinical outcomes in terms of both vision and central macular thickness among the dexamethasone patients, especially in the regional areas. In the regional areas, it actually surpassed non-inferiority and achieved superiority. Limitation always in Aboriginal healthcare is a lack of attendance, so 50% non-attendance. And this was with an Aboriginal liaison officer that we used, and we had other staff members providing free transport and patient reminders and all this stuff. So in the real world, 50% is actually very good attendance, unfortunately. And real world attendance we have found in our outreach service in Western Australia, it can actually be closer to 20 to 30%. So you also have to be very mindful of this, regardless of which drug you use. I'd just like to finish by repeating that this is the first ever ophthalmic randomized controlled trial to have exclusively recruited Aboriginal or Indigenous patients anywhere. And the model that we used, the template that we used to create the study, we believe should help future Aboriginal-led research to be carried out in places like Australia, but also Canada, South Africa, the USA, places where there is an Indigenous population within a broader non-Indigenous population. I'd like to thank all my collaborators and colleagues on this study. That's the end of my talk. Thanks for listening, and I'm happy to take questions at the end. Thank you.